Hi, so I did like 42 questions over the past 7 days in cardiology. I am gonna revise them, and when I revised the immunology I studied earlier with my video, it reduced my revision time a lot. So I think spending time to record the videos is going to help me for the exam. So I'm continuing to make the videos, and again, with all the conditions I'm going to discuss, it doesn't have all the key features, etiology, pathophysiology, and treatment modules. It's just the clues and key points I found in the question which helped me to pick the answer faster and the most correct answer. Also, it's been 8 years since I graduated. On top of that, if you add 3 years of my medical school, I studied preclinical subjects before 11 years. So sometimes I kind of wanted to go back and check the basic physiology and pathophysiology as well. So firstly, heart failure. Heart failure presents with progressive exertional dyspnea. We find increased jugular venous pressure, and also there is increased brain BNP. So what happens in decompensated heart failure? Before that, the causes of heart failure, the first one is pulmonary edema, but sometimes the heart failure can occur without the pulmonary edema because the pulmonary edema increases gradually over time. The other causes of decompensated heart failure is increased ventilatory demand, ventilatory and peripheral muscle dysfunction. So to go in detail about this decompensated heart failure, we need to study about the RAS and sympathetic pathways and how it exacerbates the heart failure. So let me start with the heart. In heart failure, the afterload and preload is increased. The increase in afterload and preload causes heart failure, that is volume overload, reduced cardiac output, and myocardial stretch. So the heart failure has volume overload, and the heart is not able to pump out all those and that causes reduced cardiac output, and there is also myocardial stretch because of the increased afterload and increased preload. This causes decreased baroreceptor stretch and decreased renal perfusion. So this causes vasoconstriction, salt and water retention to increase the BP. So that's how the RAS usually works, but when it tries to help increase the BP in long term, it kind of is harmful if it in the long run. So how this baroreceptor works is that when the baroreceptor identifies a high BP, when the BP is high, how this baroreceptor works is the BP is high, the vessel wall stretches, baroreceptor fires more impulse. This stimulates vagus and gasopharyngeal nerve that reduces heart rate and cause vasodilation, and then the BP drops. So how in this vicious cycle of RAS sympathetic pathway, which exacerbates the heart failure in the long run, the baroreceptor has increased atrial natriuretic peptide and increased brain natriuretic peptide, which causes vasodilation, salt and water excretion, and the afterload and preload is decreased, which counteracts heart failure. So I also wanna go over what happens when the renal perfusion is low and how the body reacts to it by this RAS system. The low BP, low sodium concentration, and low renal perfusion, if the kidney senses it, kidney releases renin from juxtaglomerular cells. Renin converts angiotensinogen from liver to angiotensin 1. Angiotensin converting enzyme converts in lungs. This happens in lungs. In liver, angiotensinogen is converted to angiotensinogen from liver is converted to angiotensin 1 in liver by renin, and in lungs this angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, And the effects of angiotensin 2 is vasoconstriction, increase in BP. This stimulates aldosterone from adrenal cortex. That increases sodium and water reabsorption in kidney. This also stimulates ADH, vasopressin, for water retention, and angiotensin 2 also stimulates thirst. So I have kind of studied about heart failure and the causes of heart failure, and separately the RAS system and the vicious cycle of RAS system, and how the natriuretic pathway compensates the heart failure. So I have these details, separate stuffs. I hope when I study the question I can relate to it and see what's going on. And the second one is pericarditis. The features of pericarditis is the chest pain worsens with deep inspiration. The chest pain worsens with deep inspiration. And one another more important key feature is that it improves on leaning forward. In ECG, you will find diffuse ST elevation in all leads except the reciprocal AVR lead. And sometimes you also find PR segment depression. So where do you see pericarditis? It can be seen in post-cardiac injury syndrome, Dressler syndrome. So what is Dressler? The Dressler syndrome, if the peri-infarction pericarditis is early, then it's post-myocardial infarction. If it is late, then it is Dressler syndrome. Dressler syndrome occurs after 2 to 6 weeks. What is Dressler syndrome is? It is autoantibodies against pericardium after MI. Autoantibodies against pericardium after MI. So the features of Dressler syndrome is that fever, pleuritic chest pain, pericardial friction drop. Please remember that, because if you or I see pericardial friction drop, pericarditis should be the first thing which comes to the mind. And diffuse ST elevation and PR depression, kind of similar to the pericarditis, but it occurs very later than the post myocardial pericarditis. The etiology other than the myocardial infarction is viral or idiopathic, autoimmune diseases like systemic lupus erythematosus, uremia, acute or chronic renal failure. Okay, that's all about pericarditis. And the third one is post-cardiac injury syndrome. I also have mechanical complications of myocardial infarction later, but for now in this post-cardiac injury syndrome, which is the Dressler syndrome, I'll go in detail. So the pathophysiology is that it is an immunologic response to cardiac injury. So there is a damaged mesothelial pericardial cells. This causes blood in the pericardial space. Clinical feature is malaise and sometimes fever. The lab will have increased erythrocyte sedimentation, right? And treatment is high dose NSAIDs, aspirin 1000 mg or ibuprofen 800 mg every 6 to 8 hours. However, anticoagulation medications are avoided to prevent hemorrhagic pericardial effusion. Anticoagulation medicines are avoided in post-cardiac injury syndrome because it increases the risk of hemorrhage into the hemorrhage of pericardial effusion. And along with NSAIDs, colchicine sometimes is used for prophylaxis in patients undergoing cardiac surgery. Corticosteroids are used when NSAIDs are contraindicated. In contrast to pericarditis, this develops within weeks rather than days, and most times it is also self-limited. The next one I studied is Kawasaki disease. Kawasaki disease. Kawasaki disease is a vasculitis characterized by more than 5 days of fever and any of the 4 of the following findings. I'll go over the 5 findings, and this will lapse with other conditions as well. Those are the differential diagnosis for this clinical presentation. So what are the 5 features? Is conjunctivitis, injected conjunctivitis. This is bilateral, non-exudative, and limbus sparing. Non-exudative, bilateral, limbus sparing. Oral mucosal changes like erythema, fissured lips, strawberry tongue. We will also see strawberry tongue and 2 other differential diagnoses later. Polymorphous rash often begins in polymorphous rash often begins in perianal area. Distal extremity changes, erythema, edema, desquamation of hands and feet. Cervical lymphadenopathy with the lymph node enlargement more than 1.5 centimeter. So what are the 5 features of this Kawasaki disease? Is that conjunctivitis, non-exudative, bilateral, limbus sparing, cervical lymphadenopathy. What are the other 3 things? Oral mucosal changes and polymorphous rash distal extremity changes. What are the oral mucosal changes? Erythema, fissured lips, and strawberry tongue. We can think of Kawasaki disease because in the question I studied there was actually a picture of a kid with the fissured lips and strawberry tongue. And erythema, polymorphous rash that often begins in perianal area. Distal extremity changes. What are the distal extremity changes? Erythema, edema, desquamation of hand and feet. And the child will also always be irritable, which is like for every condition. And this is mostly self-limited, but the risk of cardiovascular sequelae is most common, especially there is a risk of cardiovascular sequelae, so they need an ECG if we suspect Kawasaki disease, especially coronary artery aneurysm. And not just one ECG is enough, it needs to be repeated over several weeks as well. The risk is higher in infants and with infants who has fever for more than 14 days. The treatment is IVIG after 10 days of symptom onset. So the treatment for Kawasaki disease is IVIG after 10 days of symptom onset. Most repress over years, but large aneurysm causes MI and sudden death. Most repress over years, but if there is a cardiovascular sequelae, then there can be MI and sudden death. Now coming to the differential diagnosis for Kawasaki disease, there are 4. Scarlet fever, parvovirus infection, pharyngoconjunctival fever, and measles. The scarlet fever, parvovirus infection, measles, and what is the third one? Pharyngoconjunctival fever. So these clinical features kind of interlapses with the scarlet fever. So Kawasaki disease, scarlet fever has strawberry tongue, which we saw in Kawasaki disease as well. They have fever, Kawasaki disease had it. Cervical lymphadenopathy, Kawasaki disease had it, but they don't have any maybe distal extremity changes and conjunctivitis. Yeah, there is no pharyngitis, no conjunctivitis, no extremity edema. Parvovirus infection also has fever and rash. The classic slapped cheek appearance is in parvovirus infection once the fever resolves. And sore throat, cough, headache, and the kids with parvovirus infection also does not have extremity changes, no extremity edema. And pharyngoconjunctival fever, this is here also no extremity edema. So in all those things, scarlet fever, parvovirus infection, and pharyngoconjunctival fever, there is no extremity edema. And pharyngoconjunctival fever is mostly caused by adenovirus. The pharyngoconjunctival disease is mostly caused by adenovirus. The symptoms are fever, cervical adenitis, and conjunctivitis, which is also something we saw in both of the above. No, not both of the above. The scarlet fever, there is nothing mentioned about conjunctivitis and parvovirus infection. And here also we don't have any pharyngitis. Measles has almost everything as the Kawasaki disease, but I don't know, let me see. So they have non-exudative conjunctivitis, Mucositis, strawberry tongue. So the strawberry tongue is seen in Kawasaki disease, scarlet fever, and measles. There is also rash, there is extremity changes, cervical lymphadenopathy is also there, and more than or equal to 5 days of fever, and ECG is indicated for this patient too because of the risk for CA aneurysm. So what the question had was, the kid had 1 week of fever, crankier than normal, decreased oral intake, temperature was 102.9 Fahrenheit, BP 90-60 mg, and heart rate 135 per minute. Physical examination showed bilateral conjunctivitis, 1.7 centimeters cervical lymphadenopathy, by cardiac auscultation, normal rhythm, no murmur, rubs or gallops. Trunk extremities had a blanching maculopapillar eruption. Oh my god, the next one is digoxin toxicity. This is the one which confused me the most because of the positive inotrope and negative chronotrope thing of this digoxin. So I just could not get the digoxin toxicity into my mind, but I think I have kind of put it together. So the causes of the digoxin toxicity, what does it cause? It causes cardiac arrhythmias, sinus bradycardia, ventricular tachycardia, junctional rhythm. And arrhythmia is not diagnostic of digoxin. Wait a minute. Yeah, I just reframed the frame because only my head was coming. So arrhythmia is not diagnostic of digoxin toxicity. The most specific finding for digoxin toxicity is atrial fibrillation with atrial tachycardia with AV block. Also, it's always mostly Mobitz type 1 AV block, and I'm also planning to study all the 3 degrees of AV block and make a video of it separately. But for now, the AV block, the most common AV block you find in digoxin toxicity is Mobitz type 1 AV block. And before that, so what does digoxin normally does when it is given for the treatment of heart failure and atrial fibrillation or atrial flutter? So digoxin is mainly used in heart failure, and it's a positive inotrope, which means it increases contractility, and it is also given in atrial fibrillation, atrial flutter, that decreases AV contraction and controls ventricular heart rate, right? So I don't know if I need to go over this digoxin. So yeah, digoxin, what normally does is it inhibits sodium potassium ATPase channel. So there is increased intracellular sodium, increased intracellular calcium that causes strong contractions. So how this increased intracellular calcium causes strong contraction is that the increased intracellular calcium sends when the action potential arrives, the increased intracellular calcium sends more calcium to the cell's cytoplasm. Then the more calcium, Ca2 plus, binds to troponin C on the actin-myosin filaments. This actin-myosin bridge causes stronger contraction. So what is this actin-myosin bridge? Actin-myosin bridge is what generates contraction. Actin is the thin filament, myosin is the thick filament. As I said, I had to go back and study these basics because I was a little confused about everything. And troponin and tropomyosin regulates binding controlled by Ca2 plus. Now this explains how digoxin is a positive ionotrope and it increases contractility. In toxicity, what happens is there is too much intracellular calcium in atrial cells. So there are delayed after depolarization. They are called DAD. So with the increased calcium, even after the first action potential, it causes more ectopic action potentials. Those are called delayed after depolarization, DAD. This causes ectopic atrial impulse and atrial tachycardia. So coming to the AV block, this is about the contractility of the digoxin. Coming to the AV block by digoxin, normally digoxin increases the vagal tone on AV node, parasympathetic tone, and that slows AV conduction and prolongs refractory pathway. That's why we use it in atrial fibrillation or atrial flutter. In toxicity, there is excess vagal stimulation, so the AV node failed to transmit atrial impulse. This causes first or second degree AV block, but it's mostly Mobitz type 1 AV block, second degree. Okay. I kept on writing these things over and over again because I keep confusing the positive inotrope and negative chronotrope. So in digoxin toxicity, you see sinus bradycardia. Why? Due to increased vagal tone, slow AV node firing. ECG will have slow regular rhythm with normal PQRS relationship. So in regular rhythm with normal P wave, but there is bradycardia. And ventricular tachycardia. If there is ventricular tachycardia because of digoxin toxicity, then there is also delayed after depolarization, DAD, and this causes ectopic ventricular activity. ECG will have alternating QRS axis, very suggestive of digoxin toxicity. Alternative axis of QRS waves, that is very suggestive of digoxin toxicity. And there is junctional rhythm. What is this junctional rhythm? There is no P wave, or the P wave, the morphology of P wave is very bad, is the word I could use. So SA node is in junctional rhythm, SA node is suppressed, AV node automatically takes over. That's why there is no P wave or inverted P waves. And here too you will find normal QRS rate. I think I have written this almost 4-5 times in this 3-4 pages because I just could not remember this positive inotrope and negative chronotrope. Even now I have to refer to it. And also I have written the digoxin toxicity pathophysiology, how the digoxin is increased in serum. So digoxin competes with potassium to bind myocardium at the sodium potassium ATPase. In hypokalemia, increases digoxin binding, thereby increasing serum digoxin. So there is no enough potassium and the digoxin easily binds, causing digoxin toxicity. Maybe I need to study this more. Let's see. Okay. The next one is sick sinus syndrome. The primary contributor to sick sinus syndrome is that it is age-related or cardiomyocyte fibrosis. ECG will have sinus bradycardia with sinus passes, sometimes sinus arrest. ECG will have sinus bradycardia, sinus passes, sometimes sinus arrest. The treatment for sick sinus syndrome is pacemaker. So the side effects of having a pacemaker, for that, first we need to see how the pacemaker passes through. It is placed in superior vena cava, then it goes to right atrium, then it goes to the tricuspid valves, and then it ends in the terminate in the endocardium of right ventricle. So the side effects of pacemaker is the damage to tricuspid leaflets, inadequate leaflet closure, and it happens in 10 to 20% of cases. And the next one we are gonna see is hypertrophic cardiomyopathy. It is autosomal dominant due to sarcomere gene mutation. And if hypertrophy is due to hypertension or other cardiovascular diseases, it is not considered as hypertrophic cardiomyopathy. Many patients are asymptomatic. Clinical features are exertional dyspnea, chest pain, fatigue, palpitations, presyncope or syncope. So the clinical features of hypertrophic cardiomyopathy is that exertional dyspnea, chest pain, palpitation, presyncope or syncope. So what happens in hypertrophic cardiomyopathy? The left ventricular septal valve is hypertrophied. In hypertrophic cardiomyopathy, there is the increase in the left ventricular septal valve is thickened. Okay, so that is mostly common in the basal anterior septum, asymmetric septal hypertrophy, because it's mostly, if it is mostly in basal anterior septum, then it is asymmetric septal hypertrophy. And some patients have systolic anterior motion of mitral valve because of this septal valve hypertrophy. Some patients have systolic, when the ventricle contracts, the mitral valve has an anterior motion. This contact between mitral valve and ventricular septum causes left ventricular outflow obstruction because the mitral valve cannot open fully. So this some patients have systemic anterior motion of mitral valve. Contact between this thickened ventricular septum and mitral valve causes left ventricular outflow obstruction. This causes harsh systolic murmur. Best heard at the apex and left lower sternal border. That's where you hear a lot of murmurs involved with mitral valve. And abrupt standing from supine position intensifies the intensifies the murmur. How it does that is, so when the patient stands up, because the blood goes down and pools in the legs, and this naturally causes decreased venous return. However, in cardiac myopathy, what happens is, because of the decreased venous return, the preload is decreased as well. When the preload is decreased, what is preload? The amount of blood filled in the ventricle before it contracts. So when the preload is decreased, the ventricle is not as big as it is. So the obstruction because of the septal valve thickness and mitral leaflet is higher. This causes higher left ventricular outlet obstruction. And in most cases, however, who don't have a left ventricular outlet obstruction, the murmur should smoothen out, but it is the hypertrophic cardiomyopathy is the exceptional case. And the effects of maneuvers on hypertrophic cardiomyopathy: in Valsalva maneuver and abrupt standing, nitroglycerin administration, these three causes decreased preload, which causes the volume of blood to be low and increase in intensity of murmur. Sustained hand grip will increase the preload, so the ventricle dilates more. That relieves the obstruction a little bit, so the blood volume is high and the intensity of murmur is low. In squatting position, there is increase of both afterload and preload, so the left ventricle blood volume is high, however the murmur intensity is low. So how much the ventricle dilates with the afterload and the preload, the murmur intensity of the murmur can be correlated. If it is more, the intensity is less. And passive leg rise will also cause increased preload, which also increases the left ventricle blood volume and decrease in murmur intensity. And the next one I'm gonna study is or revise is etiology of syncope. So there are three types of syncope we are gonna study now. This is reflex syncope, orthostatic syncope, and cardiac syncope, reflex syncope, orthostatic syncope, and cardiac syncope. Sorry. So the examples of reflex syncope is vasovagal, situational. What causes reflex syncope is that vasovagal, it can be situational, carotid sensitivity. So vasovagal, the triggers can be emotional stress, prolonged standing, and there is always prodromes, nausea, sweating, warmth. So how this emotional stress or prolonged standing causes the vasovagal syncope is there is sudden increase in sympathetic activity initially. So when the patient is dehydrated, the volume is low, the BP is low, so the sympathetic system is activated to counteract that. Heart contracts strongly, activates mechanoreceptor C fibers. This is misinterpreted as high pressure. Then there is signal to vagal nerve, bradycardia and vasodilation happens. There is decreased systemic venous resistance, and there is decreased cerebral perfusion. But just the receptor, C fiber receptors, the name I have to go and study again. So how it goes is that there is sudden sympathetic activation, which causes strong heart contractions, which activates mechanoreceptors, C fibers. This is misinterpreted as high pressure. And then there is signal to vagal nerve to decrease the pressure. This causes signal to the vagal nerve to decrease the hypertension. This causes bradycardia and vasodilation. There is with vasodilation there is decrease in systemic venous resistance. This causes low cerebral perfusion and thereby syncope. Same with micturition for the situational causes for reflex syncope is micturition, defecation, swallowing, or coughing. All of this kind of follow the same pathway. And the carotid sensitivity, tactile stimulation of standing, advanced age, carotid atherosclerosis, all can cause reflex syncope. So with tactile stimulation of standing is that you're standing for so long, blood pools in the leg, and there is low systemic vasoresistance and thereby low organ perfusion and all that. So the second one is orthostatic syncope. Orthostatic syncope, what can cause the orthostatic syncope? Medications, vasodilators, alpha-1 blockers, anti-hypertension medicines, inotropic, chronotropic blockers. Chronotropic blockers. So how does this inotropic or chronotropic blockers can cause syncope? What does the heart rate decreases, contractility decreases, low outflow, low systemic vascular resistance, low organ perfusion. Correct. Okay. Hypovolemia, exactly that. And autonomic dysfunction, the autonomic dysfunction is seen in advanced age and predisposing disease like DM and Parkinson's. And cardiac syncope. 3 causes I studied for this cardiac syncope is left ventricular outflow obstruction. In this left ventricular outflow obstruction, the syncope was with exertion, and LV outflow obstruction, you hear the systolic ejection murmur. We already studied it now in hypertrophic cardiomyopathy. Ventricular tachycardia, there is no warning symptoms, and cardiomyopathy and ischemic heart disease. Okay, ventricular tachycardia, no warning symptoms. Cardiomyopathy and or ischemic heart disease can cause syncope. How the heart does not contract properly, so the outflow is low, blood volume is low, then again the same cycle. And QT interval prolongation can cause ventricular tachycardia. I think I need to study how ventricular tachycardia causes cardiac syncope. Just give me a minute. So how this ventricular tachycardia causes syncope is that with ventricular tachycardia, the ventricle contracts and relaxes so fast, not enough blood is pumped out, then again the same cycle. And conduction impairment, preceding fatigue or lightheadedness, and if the patient has ECG abnormalities like sinus passes or dropped QRS, everything involved with cardiac output can be a reason for cardiac syncope. But one important thing to remember about cardiac syncope is that that does not have any prodromes. If there are no obvious triggers, if there are no prodromes, it could be a cardiac syncope, especially something like arrhythmia is going on. Pulmonary embolism, I left a whole ass page that thinking so many questions will come that I can fill this up maybe, but I'll be studying it in respiratory system. So far what I studied in this pulmonary embolism is that diagnosis is CT angiography. Sometimes it presents with syncope, but always have chest pain, dyspnea, hypoxemia, tachycardia. Treatment is acute management is heparin product. Long-term management is apixaban. Apixaban is a direct factor XA inhibitor. Acute management is heparin product. Long-term management is apixaban, a direct factor XA inhibitor. So even for supraventricular tachycardia, I left a whole page, but it's like just one point. Maybe in the further blocks, I will study more about supraventricular tachycardia. Investigation of how the supraventricular tachycardia investigated is adenosine briefly slows conduction through AV node and help identify and treat SVT, supraventricular tachycardia. So adenosine briefly slows the conduction through AV node and helps identify and treat supraventricular tachycardia. How this adenosine helps us identify supraventricular tachycardia is that adenosine binds to A1 receptors in the AV node and it blocks the AV node. If the AV node is blocked, AV node is blocked by hyperpolarizing it, and most supraventricular tachycardia depends on re-entry circuit through the AV node. Blocking the AV node breaks the circuit, rhythm resets to normal sinus rhythm when adenosine is given. And next thing we are gonna see is high dose niacin therapy. So what happens with the higher doses of niacin? Niacin is used in hypertriglyceridemia. The features of high dose niacin is cutaneous flushing, generalized pruritus. This is called niacin induced vasodilation. So cutaneous flushing and generalized pruritus. Niacin induces, so how this cutaneous flushing and generalized pruritus is caused is niacin induces release of histamine and prostaglandins. Aspirin given before 30 minutes of niacin administration can help overcome the side effects because aspirin inhibits prostaglandin formation. The next thing I'm gonna study is non-ST elevation MI, NSTEMI. So the NSTEMI is mostly in the inner wall, so there is no ST elevation, maybe there is ST depression. The features are chest pain, ST depression, troponin elevation. These people with ST elevation needs long-term medical therapy, which is very important clue for the answer in the question I studied. Needs long-term medical therapy. What are those? Dual antiplatelet therapy. It is very important in patient with NSTEMI. Dual antiplatelet therapy is with aspirin and P2Y12 receptor blocker like clopidogrel, prasugrel, or ticagrelor. We will give aspirin, and along with aspirin, we will also give P2Y12 receptor blocker. Examples are clopidogrel, prasugrel, and ticagrelor. At least for 12 months after stent placement. This is important. And also we will be treating them with beta blockers AC inhibitors are angiotensin 2 receptor blockers. HMG-CoA reductase inhibitors, which are nothing but statins. Aldosterone antagonists, spironolactone, eplerenone, in patients with left ventricular ejection fraction lesser than or equal to 40%. And when I go back and study this question, I think I'll read more about it. But important thing is they need dual antiplatelet therapy. But the question had something about this dual antiplatelet therapy that we need to know about it. Maybe I can go back to the question and see why it was, how the clue was found in the question. So the next thing is jugular venous pressure. Usually the wave, jugular wave, is like this. Oh, it's inverted. Anyway, so the jugular wave is like this. This A wave is, this is A wave, this is C wave, this is V wave, this is X, and this is Y. So A wave is atrial contraction, C wave is ventricular contraction. A wave is atrial contraction, C wave is ventricular contraction. The atrial contraction, C wave is ventricular contraction, and V wave is maximal atrial filling. V wave is maximal atrial filling. Y wave is atrial emptying into right ventricle. Y wave is atrial emptying into right ventricle, and the X is atrial relaxation. So A, atrial contractility, V, ventricular contraction, and X, atrial relaxation, and A, B, C, X. V is maximal atrial filling, Y is atrial emptying into right ventricle. So this is the normal jugular venous pressure wave. There is something called Cannon A waves, which are tall A waves. How are they caused? Surge in jugular venous pressure. So what is A wave? Atrial contractility. So when the pressure, the venous return is so high, the atrial pressure is high, which in turn causes the jugular venous pressure to be high. That causes the tall A waves, Cannon A waves. Cannon A waves can be seen in any arrhythmias involving atrioventricular dissociation. When the atria and the ventricular are not coordinated very well, the atrium will have a lot of pressure, which will cause this jugular venous pressure. The example of atrioventricular dissociation is ventricular tachycardia, of course. In the ventricular tachycardia, there is self-propagation within ventricles without communication with the atria. Other arrhythmias with Cannon A waves are complex AV block, so there is no communication between them two. And premature ventricular contractions, again atria and ventricle are not coordinated. Symptoms associated with Cannon A wave is headache, jaw pain, sensation of neck pulsation. Headache, jaw pain, and sensation of neck pulsation. Absent A waves in atrial fibrillation. ECG shows irregular rhythm. In atrial fibrillation, there is no A waves. A wave is atrial contractility, and let's think why atrial fibrillation. Yeah, it pumps so fast and no blood is it doesn't pump fully or pump regularly, so no blood goes out into the JVP is what I'm thinking. Let me check what I said. In atrial fibrillation, the atria contracts like not fully contracting, not dilating, it's just fibrillating. So there is no real atrial pressure and there are no A waves in JVP waves. And flat and wide descent. What is Y? It is the filling of right atrium into right ventricle. So we see a flattened white wave which is caused in pericardial effusion due to external right ventricular compression. So the external right ventricle, right ventricle is compressed due to the external pressure. So the blood from the atrium is not completely drained into the ventricle, which causes flattened Y wave. Similarly, like pericardial effusion, cardiac tamponade, It can also cause flattened Y wave and prominent V wave and absent X wave descent. Before that, I just want to remember what is V wave, atrial filling, and what is X, atrial relaxation. So these are prominent due to increased atrial pressure. And also I have a whole last page left for pericardial effusion, thinking I will get a lot more questions about it, but no, maybe I'll study those in respiratory system. But here I have just written down pericardial effusion leads to cardiac tamponade, hypotension, dilated neck veins, muffled heart sounds are the features, and also on auscultation you will have dull sounds. In auscultation you will see dull sounds. Okay, and the last one for this video is gestational hypertension. So usually what is chronic hypertension? If the pressure is more than 140 mg, systolic is more than or equal to 140 mg, and diastolic is more than 90 mmHg. But in gestational hypertension, the new onset at 20 weeks or after 20 weeks, if this goes to this normal, the hypertensive pressure level, that is called gestational hypertension. With preeclampsia, we see the same gestational hypertension with proteinuria and or end organ damage. Eclampsia is preeclampsia and new onset tonic-clonic seizures. And that's all about this. So far I have covered 15 questions and I still have 30 questions. Maybe if I do 15 and 15, maybe two more videos. Let's see, and I hope that recording this video helps me saves a lot of time, because I don't know, I also have a feeling maybe I should just study, revise and go. But why I keep doing this is it helps my revision faster. When I revise, it doesn't take much time. So I think I'll continue recording the videos. Let's see. Bye, and I hope we all pass the exam. If even one person sees this video, or even if it is just me using this videos to revise, I hope I pass the exam. Bye.